Thank you. Thank you, Sue, for that introduction, and welcome everybody to today's Midwifery Festival. I'm starting off with a fairly gentle introduction. It's often in when we're working as midwives and healthcare support workers, life is incredibly busy, and actually we don't often have time just to take a little bit of time out and just reflect on exactly what we're doing, what would we like to be doing. So in my presentation, that's what I'm going to be doing, is just let us stand back and think a little bit about where we are and where we would like to be. So I'm just going to start sharing my slides with you. So we're going to be looking at, everyone's talking about the new normal. What does new normal mean post-COVID? We changed so much, and where's the balance between what do we keep from the changes that we had to make to clinical care during the COVID pandemic, and what's better that we go back to doing what we did before. So let's just we're just going to be thinking about that for the next few minutes, and I particularly thought I'd focus on antenatal care. We could be looking at this in exactly the same way around intrapartum care and particularly around postnatal care, but I thought let's just concentrate on antenatal care for this morning. And I'm very conscious that how exciting that we've got people joining from around the globe, and of course care is very different in different settings. So it would be wonderful to hear in the chat how different countries have responded to the COVID pandemic in terms of providing their antenatal care, and again what they're thinking of keeping and what they're thinking of changing as time goes by. So let's just take us back first of all. Most of you won't need very much reminding of what was going on a year ago, but suddenly we were thrown into a situation where all our established procedures, are very carefully drawn up pathways for care, were almost shredded overnight, and we were told to completely redesign services and to introduce virtual care for women that had been considered for many years, but we hadn't quite ever got over the hurdle of providing it. But virtual consultations were rapidly set up, particularly for antenatal care. The pathways for screening and for providing care in terms of the numbers of blood pressure checks and urine checks and pathways for screening for gestational diabetes were suddenly changed and to some extent compromised, which was very unsettling for a lot of healthcare professionals and perhaps for women. We reduced home visits. Midwifery care in the UK is still very proud of being able to offer home visits, often for some antenatal care and some postnatal care, but that was more or less stopped. Face-to-face antenatal and postnatal groups were discontinued. We put severe visiting restrictions on visitors and partners coming into our hospitals and into our clinics. And midwifery-led services were reduced. In the UK, many midwifery-led units were closed temporarily, and there were other effects on hospital services. And all that happened literally within a couple of weeks. So massive change and massive reorganisation. So where were we before the COVID pandemic? Well, in 2003, NICE, the National Institute for Health and Care Excellence in the UK, produced their first guidance, maternity guidance, and that related to antenatal care. And it was at that time that across the UK, we introduced a new schedule of antenatal checkups. Prior to that, women had been seen in what we considered a very traditional model, which was actually introduced in the 1940s of seeing women for checkups monthly until 28 weeks, fortnightly to 36 weeks, and weekly until they gave birth. And that was very established practice. Everybody did exactly the same. And then in the 1990s, there were a series of certainly 3 randomized trials conducted in England, which looked at offering women different schedules of antenatal checkups with reduced visits. And they were found to be effective and acceptable to women. And it was those trials and information that then informed the NICE antenatal care guidelines and pathways in 2003. And so that was very well established practice. Those pathways of care were well established. And then suddenly the COVID-19 pandemic hit us. And what did that require? Well, it required overnight these massive changes in care. And the RCOG and the Royal College of Midwives pulled together very rapidly to produce new guidance on care, and that included antenatal care provision. And to their credit, the professors of the Royal College of Midwives pulled together and produced ultra rapid reviews of evidence to try to inform care in a pandemic setting. But if you look at the normal ways in which we produce guidance, they would always be informed by the best research evidence, by clinical expertise, and by women's and users' values and preferences. But we were thrown into a situation where actually we had very little evidence relating to a pandemic suitable schedule of care. So guidance was very much driven by clinical expertise and by clinical opinion, but clearly informed by the little amount of evidence that was around. But what we would produce then was very much a scaled down package of care compared to what we had previously been providing and what we had previously considered to be good care. And this is an article that was published in the British Journal of Obstetrics and Gynecology, which looked at the service provisions and the way that antenatal services did in fact change in practice. And that this was produced from the RCOG. And what did they find? Well, they had a fairly good response rate. Around just under half the units in the UK responded, of whom 70% reported a reduction in antenatal appointments. So absolutely in line with what had been suggested that they should be doing. 89%, so the vast majority, were using some sort of remote consultation process. 70% had changed screening pathways for gestational diabetes in pregnancy, and again, that was very much a reduced schedule compared to what we'd been using before. So we know that the recommended pathways were actually being rolled out in practice. But of course, it's important to know, so how was that received? What was the effect of that for women? And at this time, I was part of a group, the RISK study, which is a study which was primarily funded and initially funded by the Wellcome Trust to look at the way that women receive information about risk in pregnancy and labour in the postnatal period, and how they perceive public health messaging. And we'd completed that work prior to the pandemic, but we felt we couldn't miss the opportunity to go out and ask women how they were finding the new COVID socially distanced antenatal and maternity care that women were now receiving. So this was an online survey which we conducted last summer, just over 500 participants. So not huge numbers, but it's still 500 women and their views. The majority of the participants were still pregnant, and around a third had given birth to a baby during the pandemic. 45% were expecting or had their first baby, and around 26% of women had underlying medical conditions, which you would then anticipate would mean that they required some obstetric input or GP input into their antenatal care, and around 40% were receiving obstetric as well as midwifery care. So how are women finding the new package of virtual antenatal care? Well, what we found was around half of the participants had what we would describe as a routine checkup, an antenatal checkup, by phone or by other virtual means. So that was just a face-to-face conversation, a virtual conversation that replaced the usual hands-on checkup with blood pressure and urine monitoring and the midwife doing an abdominal palpation. Some had experienced a virtual appointment with a doctor, either an obstetrician or a GP. Perhaps not surprisingly, for a group of women who had chosen to participate in an online survey, very few reported having difficulties with the technology in terms of delivering and receiving contact with maternity services. But of course, that may not be reflective of the women. But when we asked women the extent to which the virtual services were meeting their needs, this was really not encouraging at all. So only about 1 in 8 women, so 12%, considered that their needs were entirely met through the new schedule of antenatal care of combined virtual and reduced face-to-face. And concerningly, around a quarter felt that their needs were not met at all. So that's something that we really need to bear in mind. And I'm just thinking at this point whether you're wondering, and just thinking back to the extent to which your services changed during the pandemic, and how whether you know how women received those services. So this was a fairly typical comment from a woman. 2 of my midwife appointments have been moved, including my forthcoming 34-week appointment. At this point, I feel worried that the usual blood pressure tests that would ordinarily be undertaken for preeclampsia are being missed. And I think that's a very fair comment from a woman. Normally, in usual times, if women miss antenatal appointments, we're concerned that they're not having their blood pressure and their urine checked. So why should women suddenly think that it's acceptable and safe for them and their babies that overnight we decide to reduce our schedule of checkups? So it's perhaps not surprising that women were responding in this way. And of course, ours isn't the only survey. This is another survey which was led from Norwich, that looked at women's perceptions again and experiences of socially distanced maternity care. This survey had over 1,000, nearly 1,500 response. And again, but the theme was similar. The main area of concern was around virtual clinics antenatally, and the extent to which this virtual care, it's meeting the needs, and how acceptable they are to women. So exactly the same concerns across these 2 surveys. So we need to consider, where are we going? What are we going to be doing in the future? And this is a question that many maternity services now across the globe are considering. We've introduced and we've discovered new ways of providing care, but what do we want to hang on to, and what do we want to drop? To what extent are we going to carry on with virtual care? And when is it how do we know when virtual care meets the needs of women, and which groups of women? Are there different groups of women for whom it's more acceptable? Now, this is some work that's recently been conducted in the United States, where, of course, and I hope we've got some participants from the US online. They may still be fast asleep in their beds, so they may be catching up later on or tomorrow. But this is some work that's been designed looking at the USA. Is essentially have carried on with that package of antenatal schedules, which was commonly used in the UK up until 2003. So in the US, women are still seen monthly till 28 weeks, fortnightly to 36, and weekly until birth. And this was some work carried out just a couple of years ago to look at whether it would be feasible, acceptable, and effective to offer a reduced schedule. And that reduced schedule is very similar to the schedule that's already widely used in the United Kingdom, but also using more technology. And this is another area so we need to be considered, where's the balance between face-to-face care, virtual care, but also the introduction of self-care for pregnant women. So the schedule of what they called prenatal redesign in the USA looked at the conventional, what was there, the 14 visits being reduced to 8 face-to-face visits, but then with some nurse delivered virtual or telephone contacts in between that. But also they're providing women with the facilities to monitor their own blood pressure at home, so they can do their own blood pressure checking. And also something that midwives, particularly in the UK, are very reluctant to endorse. They provided women with a handheld Doppler so they could listen into their own baby's fetal heart. And this is something which in the UK we've been very, very almost concerned about, and we don't encourage, whereas this was actually included in this package. And what they found was actually the reduced visits were effective, they were safe, and they increased maternal satisfaction. But we also need to bear in mind that actually the reduced schedule for the prenatal redesign study is very similar to the package that's already in use and recommended by NICE for women that have had an uncomplicated previous pregnancy. So it may not be quite that different for some of us. So we need to think about what does the future look like? Do we go back to face-to-face antenatal clinics with the midwife palpating and listening in to the fetal heart when the mother requests it? Or should women be provided with a handheld Doppler so they can get reassurance themselves from that, and other methods? And what about blood pressure monitoring? We now know that women are more than capable of monitoring their own blood pressure at home, and with the use of electronic antenatal records, the technology is there now that women those devices can talk to the maternity records, so the midwife can have access and review how the woman's getting on. And what about fetal growth? Fetal growth is an issue that we've been very concerned in the last few years to try to improve our detection of babies that are not growing well in utero. And we know that although the recommended method is still abdominal palpation, we know that it's less effective than we would like it to be. And actually, would it be better if all women just had serial scans? So the technology is now there, and the environment is there that we could go to complete virtual and self-care model of antenatal care. But how do we know? Is that acceptable to women? Does that provide women with the necessary links, the opportunities to ask questions, to develop relationships? If you're looking to develop relationships and provide continuity of care through the antenatal and intrapartum period? How does that fit in? How many times would a woman want to meet or need to meet a midwife before she felt that she'd received that continuity model? Or does this provide actually far more flexibility to women and midwives? And with time, we could be developing new schedules that actually meet the needs of everybody. And although many women are saying that the virtual antenatal care that was provided in the pandemic setting wasn't meeting their needs, what we're not clear about is to what extent that was influenced, firstly, by midwives that were suddenly given a device and told to go and start doing virtual care literally overnight. So midwives were unfamiliar, they weren't confident, a lot of the care that they'd grown up with and become very familiar with was stripped away. And also women were in a very insecure environment in a pandemic, and certainly at the beginning we had no idea to the extent to which pregnant women would become very ill, their babies would be affected, and staff would be affected. So although it may be that we shouldn't tarnish and just throw out the concept of virtual antenatal care because of the setting that it had to be delivered in. So what do we still need to consider? Well, there's a lot, I think, to consider before we decide where we draw the balance. I think we need to think about what is the right balance between virtual and face-to-face care. And to what extent will that balance differ between women? We're often very good at talking about individualized care and actually pretty poor at doing it. So we like structures, we like clear pathways that midwives can say, I've done all the things in the pathway, in the guidance that it said I should do. But how do the needs of women differ? So some women won't have easy access to technology. Some women won't feel confident with technology. Some women are more vulnerable. They lead more chaotic lifestyles. We need to make sure that we've got systems in place that women that need our care, additional care and support, don't fall through the net. So we need to be careful that we don't just move into a system which meets the needs of some women, but leaves other women to be more vulnerable. And are health professionals ready to accept women-centred antenatal care or woman-led antenatal care? Are we ready to hand over responsibility for all blood pressure checks to women in our care? Are we ready to accept that actually having a handheld Doppler may be beneficial to women? The other thing that's a bit of a concern is how many surveys of COVID-related maternity care are still unpublished. Many units. I was talking to someone from NHS England the other week who think that around at least 50 surveys have now been conducted, but very few have been published. There may be good reasons for that. We submitted our paper relating to our survey to a journal before Christmas, and it's still ticking along in their system because that's what happens. Our survey results are available online, but lots of research teams may not be in that position. I'm also concerned that some maternity units may have surveyed women to find out what women think about their new package of care, and actually women just said they didn't like it, so it's easier not to put that information out in the public domain. So if you do have survey results that either you don't think you'll have the time or you don't intend to publish elsewhere, if you would like to write a blog for the risk study, we would happily load up your survey so that this information can be out there in the public domain. And as I've already mentioned, what we don't know is to what extent women's concerns about virtual care that was influenced by the wider pandemic and staff and women's unfamiliarity with the system. So it may be that actually in a more controlled environment and a more controlled rollout, we can develop virtual care that meets the needs of women and health professionals. So just some acknowledgements to say again that the Wellcome Trust funded this work, which is led by the British Pregnancy Advisory Service in London. So thank you to all our collaborators. None of this work ever gets done single-handedly. It's always in collaboration, and we thank our collaborators very much. If you are interested in reading our full report, it is available online. And as I say, we would be very happy indeed to receive a blog format or a short report if you would like us to load up any of your COVID-related surveys which were done in-house. Because you may think, I'm not going to publish it anywhere else. Well, it would be great to get it out in the public domain so that we can really hear as many voices as possible from women when we go forward and we consider, where is that balance? Do we go back to the same old, or do we really find a new normal that meets the needs of women and health professionals? So thank you.
Julia, thank you so much. That was a really useful and interesting review of COVID and the study, and then thinking about what was happening antenatally, because I know it's a massive piece of work. And I think the issue about this is very interesting that you were saying about the surveys that hadn't been published. And I'll reiterate to those of you who are watching that this would be a really good thing if you have a survey that you want to sort of share, then going through to Julia and the risk team and doing a blog would be a really good way of sharing. And the idea of getting all these different voices properly involved would be fantastic, because I know there's been so much work that's gone on throughout the country. And a lot of information, and I think it's like, and I'm sure some of you are experiencing this now as we're going along this little roadmap away from being complete lockdown, that it's difficult to remember what it was like when we started and how difficult it was, and I think Julia just presented it so beautifully, the kind of huge changes that had to be made incredibly quickly. And I know, listening to you, it feels as though everybody's sort of not forgotten it, but you've kind of almost got onto a new normal. But it's important to remember where we were and what the changes have been, and also the experiences of the women and the families at that point. I mean, they're really helpful. I mean, there's one question that's come through, and I know we've got about a minute, Julia, and it sort of makes a comment on the Doppler issue. Zoe Nelson, hi Zoe, thank you for commenting. She says, anyone worried about service users using their own Doppler for reassurance? And I know this is a discussion that's gone on. The worry is an over-reliance on this rather than focusing on fetal movements. Or do you think we're just doing service users a disservice, assuming this, and just manage what people will do anyway and embrace it? And I assume that means, lots of mums are possibly listening into their babies. But I know it's something you raised, Julia. I don't know if you wanted to make a further comment.
Yes, I can do. I think we firstly, we probably need to appreciate that actually a lot of women do now have a handheld Doppler. So we can stick our heads in the sand and say we don't like them, we don't think they're safe, we don't think women should use them. But you can pick one up on any internet marketplace at a very reasonable price. And so maybe we just need to grow up a bit and say that how can we support women to use them safely? How do we ensure that women are not using a handheld Doppler to replace what we would consider to be essential care? but also perhaps to recognise that for women that have perhaps experienced a previous pregnancy loss, a previous miscarriage, that actually that window between having a reassuring scan in the first trimester and feeling the reassurance of fetal movements is a long, fairly empty window, and in which they seek reassurance. And actually using a handheld Doppler may provide that reassurance in a safe way. Our concern then is, well, what happens if they don't find the fetal heart? They will then need extra support and care to reassure them that the baby is still well. But so these things need to be thought through. But I think just trying to ignore the issue is probably not helpful to women.
Brilliant. Thank you so much, Julia. That was absolutely fantastic. And I'm sure if we had all our audience, and there are a lot of people there, if we clapped, your hair would be pushed back with the pressure of the clapping. So thank you so much, Julia, for starting us off.